Good morning, colleagues. Good afternoon and good evening, wherever you're located. Thank you so much for your participation to this morning's or afternoon or evening meeting, whatever time it is on your side. I bring greetings from our director from Division of Healthcare Management and Occupational Safety and Health, Dr. Bernard Leonard. As you know, this meeting is part of the series that we have been organizing for all the stakeholders that are involved with the management of HIV and HIV PrEP at the UN duty stations, missions, wherever they are located globally. I think I will just beg us to just wait for like a few more minutes for some of our colleagues that are joining to just join before we actually start the presentation this morning. Where the presentation this morning is about HIV pre-exposure prophylaxis. We just wait for like maybe 1 or 2 more minutes and then we can start the presentation. So while we are waiting for some of our other colleagues to join, the presentation will take this format. After my brief introduction, then I will hand over to our presenter, Dr. Devika Dixit. She's going to take us through what we need to know about PrEP. And then after our presentations, we'll give room for 1 or 2 questions. Then after the questions, then I will wrap up by giving us some other update that we may have for us concerning HIV and HIV PrEP within the UN. Without further ado, I think we can start now. So thank you again. I really appreciate your time for joining us this morning. So this meeting, as I mentioned earlier, is about HIV pre-exposure prophylaxis. You know, most of our previous meetings have been on HIV, the basis of HIV testing, HIV PrEP. You know, we've been having a lot of queries from duty stations, from missions. What is UN doing about HIV PrEP? And that is why we thought it's high time we delivered something on HIV PrEP, so that at least all the stakeholders within the organization we know some of the basis of what we can do and what we cannot do in terms of HIV PrEP. I will hand over to Dr. Dixit to continue with the presentation. So thank you so much, and then enjoy the presentation. Over to you, Dr. Dixit.
Oh, thank you, Dr. Fola, for the introduction. I'm going to just share my screen, and I apologize. I'm getting all the people that are coming into the lobby popping up onto the middle of my screen, so just bear with me if that comes up. Just give me 1 second. Okay, can somebody just let me know verbally, not via the chat, but if you can see my screen, okay?
Yeah, we can see it. Yeah.
Okay, thanks.
Yes, we can see it.
Okay, thank you. Okay, so as mentioned, we're going to be talking about pre-exposure prophylaxis today, HIV PrEP. And I'm going to say that full word over and over again, just because it kind of sounds like HIV PEP. And so I don't want people to get confused because they're obviously completely different things. So before we get into the objectives for this talk, sorry, I do not know how to silence those sounds. So before we get into this talk, I think the reason that it's so important to know about PrEP is for several reasons. And one of the reasons is that the Global AIDS Initiative has said that by 2025, we want to have 95% of individuals who are at risk of acquiring HIV have access to preventative measures for contracting this virus. And so PrEP is one of these things. Now, of course, these goals, we may not be on our way to achieving them as we would have wished, but it's still important to be able to have access to different preventative measures so that we can eventually reach these goals, even if it isn't by 2025. Kind of related to what Dr. Fola was saying, I think it's important to know that 1 in 3 primary care physicians actually have never heard of PrEP. And if we have never heard of PrEP, then we're not going to be able to offer this as a preventative measure. And of course, this is important to know about. So for the next approximately 35 to 40 minutes, I'm going to have several objectives. The first is to describe what HIV PrEP is, as well as the different regimes, as well as their effectiveness. And then we'll talk about PrEP eligibility. And just as important as eligibility is who PrEP is really not indicated for, like where the studies are lacking, where we don't generally recommend PrEP. Then, because I know you're a little bit more familiar with PEP, we will compare the HIV PrEP, the pre-exposure prophylaxis, to the HIV PEP, the post-exposure prophylaxis, just to get a sense of how they differ and then how they are similar. It's also important to discuss PrEP in the context of other sexually transmitted infections and what protection PrEP might offer. And then we'll talk about because I know there's a broad audience here, but for the clinicians, how to consider starting as well as stopping PrEP, because PrEP is not necessarily something that we take for life, but we want to know when we can start and stop that. And then I'll end with the UN provisions for PrEP, and that will be kind of the objectives for this talk. The other thing to just quickly go through, because I use this terminology in the presentation, is these terms cisgender. So just to remind everyone, what this means is that this is a person whose identity or gender corresponds with their birth sex. So female and born female at birth. And then transgender is when your gender and personal identity are different than your sex assigned at birth. So you're born female at birth, that's your sex, and then your gender is male. I also use the terminology MSM, which is men who have sex with men. And then the last two terms, the NRTI and the INSTI, those are basically the antiretroviral medications, nucleoside reverse transcriptase inhibitor and integrase inhibitor. And so you'll see these terms throughout the presentation. Okay, so what is HIV PrEP? It is post-exposure medication, in other words, antiretrovirals, that are given to individuals who are HIV negative and are at substantial ongoing risk of exposure to HIV and thereby acquiring infection to HIV. And so every word in this sentence is really key. So it's an antiretroviral. You have to be HIV negative and you have to have substantial ongoing risk. And so substantial ongoing risk used to have a number associated with it. So you had a certain incidence and that's what's going to be your substantial risk. But in the newest WHO guidelines, they really state that one individual number, so an incidence in a local population, for example, may not be enough to base your risk on. And so you really want to look at that individual alone and say, what are their risk factors? What activities do they engage in that might put them at risk in order to make that decision? And one of the things that they say is that individuals that come to a healthcare provider to seek PrEP, so they come to you and say, I'm interested in PrEP, I want more information. By definition, the WHO says that these individuals might have some increased risk because they've actually come to see you to get medical attention and ask you about this. Now, we will talk about eligibility as the presentation goes on. And of course, I'm not just saying that anybody that comes to talk to you should be getting PrEP, but they need to be evaluated in that context. And if they are bringing it up to you as a medical provider, there may be some reason for it, and they may not necessarily disclose all their risk factors. So the goal of HIV PrEP is to prevent HIV-1 acquisition. So the data, all the studies, they're in HIV-1 and not in HIV-2. However, probably because the antiretrovirals work in HIV-2, this is probably applicable to that, that virus as well. But in general, in this presentation, we are talking about HIV-1. Now, PrEP is part of a comprehensive set of tools to prevent the spread of HIV. So you don't just give PrEP and that's the end of it. There are other things that you do together to be able to achieve these goals of preventing HIV, not just in the individual, but in the population at large. So this includes things like safe sex practices, including condom use, voluntary male circumcision, PEP, treatment as prevention, and all sorts of other things. But basically, this is one of the tools that you can use. So there isn't too much science in this presentation, but I think it's important to just discuss the HIV life cycle quickly, just in case people don't remember, and also where the drugs that we're going to be talking about for HIV PrEP act. So essentially what happens is the HIV virus infects what is called the CD4 cells. So these are T cells, T helper cells, which are the lymphocytes, a type of white blood cell that gets infected with the virus. And hopefully you can see my mouse. But basically you have the virus that attaches to a receptor on the CD4 cell. It then fuses into the cell. And because this is an RNA virus, you have an enzyme called the reverse transcriptase enzyme that converts the RNA into DNA. Then that DNA gets integrated into the CD4 cell nucleus. And then you have replication of that virus, assembly of new virus, and then budding and release, so that now this virus is going to go and infect another CD4 cell. So we're talking about PrEP specifically, and the PrEP drugs that we are going to talk about they fall into basically two categories. So the nucleoside reverse transcriptase inhibitors, so the NRTIs, which include emtricitabine and tenofovir in a combination. And then there's another drug called dapivirine. These are all nucleoside reverse transcriptase inhibitors, and we'll talk about these more in the subsequent slides. And then you've got your integrase inhibitors, which act over here at the site of integrating the DNA into the CD4 DNA. And the drug that we're talking about for PrEP is called cabotegravir. So you'll see these names coming up. Now, just note that all of these drugs, so I've put dolutegravir here, which is an integrase inhibitor that you may remember is part of the PEP, and so is emtricitabine and tenofovir. So these drugs are also used for treatment in the right situation. They're also used for PEP, but again, the context that I'm talking about here is for PrEP. Okay, so PrEP can be given basically in 3 different ways, via pills, vaginal ring, or via injection, which is the newest way that it can be given. So the pills, which are taken daily, have been approved by WHO since 2015. And since that time, these PrEP has been started to become more common in the guidelines and national programs, and there is an increase in access that's occurring globally. We're going to leave the last 2 years with COVID aside a little bit, just because there were accessibility issues. But as a whole, these pills are generally available, particularly in parts of Africa and Asia where they were not in the past, and they are being used for PrEP. So I like to, in general, not use trade names, but for this slide, I did include them just for people that might be familiar with them, and we'll talk about why in a minute. So we talked about the emtricitabine tenofovir as the 2-drug NRTI regime, and this is the abbreviation for it. The trade name for that is Truvada, but globally, we're going to be seeing it as FTC-TDF. And basically, this is indicated as daily pills for individuals who are at risk via sexual transmission or contact, or by injection drug use. Now, Descovy is also emtricitabine, but actually uses a different formulation of the tenofovir. And so then that's abbreviated as FTC-TAF. And that is actually only for risk via sex, but it also excludes individuals who are at risk through receptive vaginal sex. So this would be cisgender female or transgender. So that's the difference, but basically it's the same drug. And as I said, globally, we're talking about the emtricitabine, tenofovir, disoxpril. So the data is for these pills is based on 12 randomized control trials that were then evaluated in a systematic review and meta-analysis. And if you look at these different trials, you've got basically different populations within the trials. So either you've got cisgender or you have transgender male women, and there's a different ratio in each of the studies. But essentially, when you put it all together, you find about an 80 to 85%, oh, sorry about that, an 80 to 85% benefit if you take the risk reduction if you take this pill. Now, some of the studies have said that this is as high as over 90%. Whereas there are other studies with lower efficacy. And basically, because I don't want to talk about every single study and every single number, not to confuse you, in general, the pills, if you take them, which is of course critically important, you take this pill every day, you take it the way that it's supposed to be taken, it's at over 90% efficacy. Next is the vaginal ring that has been approved by WHO since 2021. So this is the dapivirine ring that I was talking about. And again, this has a little bit more of a narrow spectrum of people that can use it, or that this has been studied in. Well, obviously, this is the cisgender women that are at risk for HIV. Now, while some countries have included this in their guidelines, at least by July 2022, which is, now like about a month ago, no country was including this in their national guidelines. So it's there, but it isn't being implemented in the same way as the pills. This is a ring that is inserted vaginally and is replaced every 28 days. There are several studies on the vaginal ring, the dapivirine vaginal ring, that showed benefit. Some of the earlier phase 3 studies like Aspire found an only 30% reduction in the risk of HIV, but Dream and Hope and subsequent studies have shown greater than 50%, maybe even greater than 65%. And again, if you're using the thing properly, regularly, it's going up to 90%. So between these two, the pills are probably still superior and have a broader range of individuals that you can use it for, but the vaginal ring may have some advantages for the cisgender women population. It might be more discreet. You don't need to take a pill and others. And so it's worth mentioning because this is also approved. So the most recent PrEP that has been approved is the cabotegravir injection. This was approved in July 2022, and this is for individuals that are at risk via sex. So we're going to talk about a little bit more with the eligibility for PrEP in a minute, but that's who this is approved for. If you are an individual who was taking the pill form, like the emtricitabine tenofovir, and you're interested in switching to the injection, as long as your risk is via sex and there's no other contraindications, again, we'll talk about some of those in a minute, there is no reason why you can't switch. Now, you don't go back and forth and keep switching all the time, but in general, if you're wanting to make a change, it is possible. The minimum weight for the cabotegravir is 35 kilos, and that's just the only other thing to know. This injection is given every 2 months, and we'll talk about this more in a second, but there you could see that there are some advantages here as opposed to taking a pill every day. So cabotegravir then, again, as I mentioned, is an integrase inhibitor, and compared to dolutegravir, which is used for PrEP, is a long-acting integrase inhibitor. It's an intramuscular injection, and then as I mentioned, you get a shot every 2 months, except at the beginning where you get your first 2 injections 4 weeks apart. That's the only exception. So these studies have been really promising with cabotegravir, and they have found almost an 80% relative risk reduction compared to the oral PrEP. So if you go back to those oral PrEP studies where the range might be kind of on the lower end of 80, maybe the higher end above 90, now you're having an additional 80% risk reduction on top of that. Now, the main reason for this, by far in these studies, is the adherence with the oral PrEP. So this is what I was kind of mentioning before, is that you need to actually take these medications for them to work. And when you see breakthrough infections or failures, it's in individuals who have not adhered to taking the medication. Now, the thing with the issue with cabotegravir is that this is not available everywhere in the world. Actually, most places it's not. There are obviously places where it is, but in general, the next steps now that WHO is working, and UNAIDS and others are working on, is to get accessibility of this medication globally. Of course, to implement something like this, you need to have the infrastructure to store the medications. You need to have the needles. You need to have a place where somebody can come and get their needles. And so these are just logistical concerns that we need to be aware of. So for cabotegravir, there are basically 4 multi-site randomized control trials that make up the data for the safety, efficacy, and effectiveness of cabotegravir. They have about just over 8,000 patients within these studies. And so it's basically it's more for your information if you ever want to look back, but these are the names of the studies that are the phase 2b/3 studies that compared the efficacy with cabotegravir and the emtricitabine tenofovir, and this was the 79% risk reduction. There was a range between the studies, and the reason for that is because, again, whether or not you were including cisgender or transgender individuals. So that is why there's a little bit of a range. With the ECLAIR and the HPTN 077 study, this was a 2A study on safety and dosing, and this is where they came up with the dosing of cabotegravir, and I have a slide at the end with all the dosing, just so that you have it for your information. So what they concluded basically with all of this, with this review, is that cabotegravir is superior to the oral emtricitabine tenofovir in this population. So the men who have sex with men or transgender women. And again, the reason isn't that the emtricitabine tenofovir doesn't work, but it's because of the adherence issue. So I just finished talking about the traditional way that you give PrEP. So the pills are every day. The ring is essentially continuous, and you switch it every 28 days. And the injection is every 2 months, except for at the beginning where it's every 4 weeks. But there is another phenomenon that I just wanted to mention because it does exist out there. There are many health authorities that use this off-label or have been for years, actually. But in 2019, the WHO actually recommended this as a potential way to use PrEP. Now, before I go into this too much, I just want to say that the data for on-demand PrEP, which has a few other names in the literature, but basically what that means is that you're using it like for a specific event. That data is only for men who have sex with men. So it excludes those who inject drugs or heterosexual men or women. And basically what happens is you do this 2-1-1 schedule where you take 2 pills 2 to 24 hours before sex, then 1 pill 24 hours after that dose, and then 1 pill 24 hours after that dose. So essentially, because of this, the way that you take this regime, which is very different than taking a regular kind of daily type of regime or the monthly injections, is that the efficacy is lower. However, what we're trying to do in these circumstances is to maybe have a bit of a risk reduction. And so this is why it's considered. And I'll talk about why it maybe doesn't work as well in a minute. So to kind of summarize, in general, if you take your oral ring and and the injection like all together is in the traditional way, not in the on-demand way. Basically, the PrEP reduces HIV transmission via the sexual route by over 90%. Now, the data for individuals who inject drugs is a little bit less. And so the data available is less, and then the effectiveness is also probably less. So it's only been studied for the pills, which shows that there's a reduction of getting HIV by just about 80%. And the intramuscular injection has not been studied in this population, so therefore is not recommended. Again, I've said this before, but it's just really so important, is that you need to take the PrEP for it to be effective. And if you miss doses, you're going to have decreased efficacy. So in this slide, we're talking about how long it takes once you've started PrEP for it to be effective. So there is a varying data depending on what your risk is. And so if you're taking the pill, it takes about a week to reach maximum protection for receptive anal sex. And if you remember the on-demand PrEP, which is for men who have sex with men, if you're taking it for 2 days, like 2 pills, one day, one pill, and one day another pill, you can see that you're not going to be getting your maximum level of protection, which is why that effectiveness is less. For receptive vaginal and vaginal sex and injection drug use, PrEP pills, again, take about 21 days to reach their maximum effectiveness. Now, of course, we're missing data for how long does it take for PrEP to actually reach its maximum effectiveness with insertive vaginal or anal sex, and there's no data on how long the shots are going to take to reach the maximum protection for sex. Okay, so I've kind of alluded to this when I've been talking about the data, but just to be really clear, this is the PrEP eligibility. So we talked about this already. My mouse has stopped working, so sorry about that. I can't find it, but basically you have individuals who are HIV negative, like we talked about, and at substantial risk of HIV, which we also talked about. You can be male, female, cisgender, transgender. It will affect which medication you use, but HIV PrEP is for everyone. It started with men who have sex with men, but the eligibility it does not matter. If you are, so there's basically 2 eligibilities. If you're at risk via sexual encounter or risk via IV drug use. So via the sexual encounter, you would be eligible for PrEP, or at least eligible for consideration for PrEP if you have a partner who has HIV. And this is particularly important if your partner has viral loads that are unknown or detectable. So if you remember, I gave a talk sometime last year where we were talking about U equals U. So undetectable equals untransmissible. So if you have a partner that has an undetectable viral load and they're on treatment, that virus is not transmissible via the sexual transmission. That is what the data shows. But if you have a partner that has a detectable viral load, or maybe has blips in their viral load, or maybe doesn't take their medication, this is an individual where you'd want to be considering PrEP. In addition, if you have individuals with inconsistent condom use or a diagnosis of a sexually transmitted infection in the last 6 months, these are also reasons to consider PrEP. Now, the reason that the STI in the last 6 months is a risk factor is because, of course, if you've contracted one STI, you're at risk of contracting other STIs, and it just indicates a possible risky behavior. And so that's why these individuals are considered potentially eligible. The next is the IV drug use population. So individuals that are sharing needles, sharing drug paraphernalia, or if you have a partner that is doing those things, where again, you're kind of going into a potential unknown risk within the partner, these individuals may also be eligible. I think the last group that's also important to mention is individuals that have received PrEP. Not everyone that's received PrEP, but individuals that have had multiple courses of PrEP and are supporting continued high-risk behavior. So I have seen patients in the emergency department, and it's their fifth course, or they're being assessed for their fifth course of PrEP. And these are really individuals where you want to be, saying, okay, if you're eligible for PrEP, you're eligible for PrEP. We finish that, and then we assess you for PrEP, because there's obviously ongoing risk here. Okay, so this is also really important, and this is basically who is PrEP not for. And the reason that PrEP is not going to be for these individuals is either because there is it isn't safe, or there's risk, or there is lack of data. So this bullet is probably going to apply to most people on the call. So PrEP is not indicated for potential exposures to blood and bodily fluid that might occur due to occupational risk. So, for example, healthcare workers or UN personnel that say you're having interaction in maybe a conflict situation and there's blood and bodily fluid exposure there. Those aren't individuals that just need to be on PrEP forever on end in case this might happen. These are individuals where you would say we need to, wherever possible, be wearing appropriate personal protective equipment. And if there is a significant blood and bodily fluid exposure that has occurred, then they would be considered for PrEP. Now, PrEP also has really good efficacy as well, depending on the type of exposure, up to 80 to over 90% as well. But then you don't need to be on PrEP the whole time in the case that this might happen. Healthcare workers also, if this is your only risk, that you're not eligible for PrEP. I'm saying this again, although I've said this in a few different ways, but you do not give this to individuals who are already HIV positive. I haven't seen this happen with PrEP, because PrEP is a little bit less frantic than when we're giving PEP. So PEP is like, we have this time, we need to give the PEP as fast as we humanly can. But with PrEP, we have a little bit more time to, make sure we have all our information, including doing some blood work that we'll talk about. But I have seen people who receive PEP that have been HIV positive at baseline, and that's totally inappropriate, right? These are individuals that warrant treatment, not PEP and not PrEP. We also do not give PrEP to individuals who have had an exposure or a potential high-risk exposure to HIV within the last 72 hours. So if you are, falling into that category, then you should be assessed for PEP, but not for PrEP. Of course, anybody who has severe allergies to drug or drug products, namely anaphylaxis, these individuals should not receive PrEP. And there is some caution that we need to use with liver and kidney abnormalities, as well as if you are co-infected with, for example, other hepatitis viruses. Okay, so the initiation and discontinuation of PrEP, this is really for the clinicians. So it is important to note that when we're talking about eligibility, like we said, it's an assessment of the individual using some of that criteria, but understanding their individual risk, but it is voluntary. And remember, if somebody is coming to you to talk to you about PrEP, there may be a reason for this, and they may not want to disclose some risk factors, because of course these things can be stigmatizing and still remain stigmatizing, though of course they shouldn't be. So you need to just be aware of that when you're having your counseling. So when we talk about ensuring an individual is HIV negative, you do a history review to look at your risk factors, but you also need to test them for HIV before starting PrEP. You're also supposed to be doing baseline HIV testing in PEP, but for PrEP, because again, it's a less, it's something that's done with more thought and consideration and is going to be a long-term thing in general. You really want to make sure you have documentation of the HIV status being negative, as well as any risk factors for, again, the history review in case an individual was potentially within a window period. You're also going to want to check renal function with the oral regimes, and you want to do blood work every 6 to 12 months in general. If you're, maybe I'll just get everyone to mute their mic if possible. So and then you would do a liver function if you're using an integrase inhibitor, and there are regular times that you're going to want to do this. You do want to screen for co-infections. These include sexually transmitted infections, as well as the hepatitis viruses that can be transmitted sexually or by other blood and bodily fluids, just because it can affect either which PrEP you use or if you can even use PrEP. Now, the thing that's important with PrEP is, as we said, this is kind of generally a long-term thing. You are going to have follow-up appointments, and they're going to be every 2 to 3 months, at least at the beginning. So if you remember that cabotegravir, it's an intramuscular injection that's happening every 2 months, except for the initial 2 doses, that means you're going to have to come for follow-up appointments to get your injection. And so actually with the cabotegravir, you're actually having more medical interaction than you may be having with your oral PrEP. But in general, you're at the beginning, you want to have closer follow-up. And as I mentioned, you are going to be doing serial blood work as well as HIV testing while individuals are on PrEP. And the frequency will reduce over time, but initially you're going to want to do this more frequently. So, I've talked about the adherence and how important that is. And that's part of the counseling when deciding if somebody should go on PrEP. You need to know if they will be able to adhere to this medication, and counseling that if you have missed doses, you will have an increased risk of failure. And if there are situations where you're going to miss doses from at least the exposure via sexual route, you should be using the individual should be using condoms. Now, PrEP is not necessarily a lifelong thing. However, it is something that you would use for the long term. And so there will be individuals where discontinuation might be appropriate. So essentially, you are supposed to stay on PrEP for the duration of that increased risk. So, for example, say you were with a partner that was HIV positive, you didn't know what their viral load was or it was detectable, but then that relationship was no longer continuing. You may or may not need to continue PrEP at that stage. And this is why you need to have a therapeutic relationship with your care provider in order to decide whether or not this is something you continue or not. One of the things that has been described with PrEP is that you may have a delayed immune response. So you may be having HIV negative while you're on PrEP, but if you've had ongoing exposure and weren't taking it properly, you might have an infection, like a breakthrough infection, present later. And so that's just something to be aware of when we're talking about discontinuing or missing dosing. So PrEP is generally quite well tolerated, all of the PrEP medications, and most often you're going to be getting the GI side effects. So abdominal pain, nausea, and diarrhea, and you may have some generalized symptoms as well, including headache and fatigue. I mentioned my mouse isn't working. So on the right side of the screen, you'll see the comparison of Truvada to Descovy. They're essentially the same. Descovy is marketed as if it was safer, and this is why I don't really like to use trade names or less side effects, but really they're approximately the same drug. Like I said, the only difference is the formulation of the tenofovir. Cabotegravir has been associated with rare instances of hepatotoxicity, which is why you check the liver enzymes before. And there are some situations, rare but do occur, that there has been some resistance mutations reported in the integrase inhibitors on those that are taking PrEP. So you're taking PrEP with your integrase inhibitor. Now you're one of the few individuals that get infected with HIV. They have checked those individuals and looked at their genotype, so which antiretroviral will work for their virus, and they have found some integrase inhibitor resistance. It is not common, but it definitely is there in the literature. But overall, the risk benefit to be able to be protecting you from HIV infection in the first place is still in favor of using the cabotegravir. Tenofovir can be renal toxic and can also, in the context of individuals that have acute renal failure for other reasons, typically we stop this drug. And so it's just something to be aware of. You may need to switch your regime because of that. Basically, the rates of side effects are the same for the oral and intramuscular regime, except for, that hepatotoxicity and renal toxicity that I talked about that are for those integrase inhibitor and the NRTI specifically. The only thing is that the intramuscular regime will give you some site reaction. There are site reactions associated with it because it's an intramuscular injection. The Depivirine vaginal ring, because it's being inserted up near the cervix, there have been reports of cervical swelling in some individuals, as well as increased risk of UTI. So that's with the ring. But as I mentioned, that really hasn't been integrated at this point into the national programs. Okay, so we're kind of nearing the end here, but I just wanted to give a quick word on PrEP versus PEP. So this seems like really simple, but PrEP is the pre-exposure prophylaxis. It has the R in it, and then PEP is post-exposure prophylaxis. And I just have a table here that compares the two. So the PrEP, like we talked about, is given daily for the pill. The ring is inserted every 21 days and is continuous, or is every 2 months and kind of indefinitely while you're having your risk. Whereas PEP is given daily for 28 days. But after that 28 days, we stop the PEP. So it's not kind of going on long term. It's more of a short term thing. Yes, there's the on-demand PrEP, but we're just comparing the traditional PrEP regimes. So PrEP is something you do not want to start within 72 hours of exposure, but PEP is something that you want to start if you've had an exposure as soon as possible, typically within 1 to 4 hours, but for sure within 72 hours of the exposure. The HIV PrEP might be 2 drugs or might be 1 drug. In the case of the emtricitabine tenofovir, it's a combo. It's still 1 pill, but it's 2 drugs, the cabotegravir injection and then the Depivirine ring. And then the PEP is, as you will recall, is the 3-drug regime with the emtricitabine tenofovir as well as dolutegravir. So this is where things are similar. I talked about this already, but in both PrEP and PEP, you want to be HIV negative. PrEP is for risk due to sexual exposure or people who inject drugs. And then PEP can be given for occupational as well as non-occupational exposures. So by non-occupational exposures, I mean the sexual exposure or for people who use drugs or who inject drugs. So I just wanted to make a comment about HIV PrEP and other STIs. I think most people are aware of this, but globally, STIs are common. They are increasing. There are multi-drug resistant organisms that are popping up. Where I work, we are having for years, actually, we've been having huge numbers of increasing syphilis cases. We're seeing tons of congenital syphilis, like once a week, we're called about a patient like that. That is really not something that we have been seeing for the last 10 years. And so it's a huge problem. So HIV PrEP does not protect against other STIs, so has no protection against that, which is why when we're talking about our comprehensive prevention, we're talking about HIV, but we're also talking about other STIs. And so this is where condom use still continues to be recommended as protection against STIs. Now, of course, with certain infections, so again, using syphilis as an example, or monkeypox or others, where you have lesions that are not being covered by the condom, obviously the condom isn't going to be effective then. But just given that we're having such a resurgence of different viruses and increasing rates of viruses and bacterial infections, it's important to note that that is still another piece, and which is why you screen for co-infections. So this slide was provided by Dr. Fola. I'll just go through it, and then in case he has anything else to add, we could just add that at the end. And this is about the UN provisions of PrEP. So as you are well aware, the UN currently provides UN PEP kits to personnel in all duty stations. But for PrEP, so everything I've been talking about in this presentation, it is not supplied directly by the UN to individual duty stations. Now, HIV PrEP can be requested by UN personnel who meet criteria after they've had an assessment with their physician. And again, using some of that eligibility criteria and that I was talking about. And it is nuanced. It isn't just like you do a checklist. No, you have to assess the individual as a whole to see if you think that HIV PrEP is appropriate. And this may or may not be covered by health insurance. So I think that particularly with cabotegravir, so that injection, the newer approved medication, I think eventually I do believe that these drugs globally are going to start getting covered. It's just that they are not covered everywhere. Where I work, we have been covering HIV PrEP, but mainly the pills because we haven't been using the injection since 2018. But I've worked in other places where it got covered by the government a lot later, and so it's so different. And then within the UN system, again, the staff insurance may or may not cover it. So just to summarize then, these last two slides are more for your information. It just summarizes our different drugs, the oral medications on the left side, the cabotegravir in the middle, and then the ring on the side, and just reminds you who you can use this medication for and then for what risk factor. So if you had to pick one thing and said, I'm only going to have one thing that's going to be useful for most people, it's your emtricitabine tenofovir, all the way to the left. That will work for men, women, cis, and transgender via sex or injection drug use risk. And then the cabotegravir is probably your second one, except that it's not studied for injection drug use. The emtricitabine TAF, so that formulation of the tenofovir, and then the dapivirine ring are for only specific populations. You just have the dosing here in case you need to look at that, and then it shows you how you would change it out. And let me see, now my mouse isn't working, so let me just see if I can get out of this. I just wanted to see if I could play this quick video here, which does not seem to be trying to work. It's just a final summary of what we talked about. It's from CDC, but I find it to be really quite good. And just while it's loading here, I also have a slide that has my references. Let's just let that play.
PrEP, or pre-exposure prophylaxis, is a medicine that can prevent HIV.
Sorry, I might have to just keep it small here.
PrEP, or pre-exposure prophylaxis, is a medicine that can prevent HIV. PrEP is for people who are HIV negative and risk of getting HIV. This includes people who have a sex partner with HIV, people who don't always use condoms, or people who have been diagnosed with an STD in the past 6 months. PrEP is also for people who are HIV negative and sharing needles or other drug injection equipment, or have a drug injecting partner with HIV. PrEP is highly effective for preventing HIV through sex or injection drug use. PrEP does not protect against other sexually transmitted diseases. Only condoms can protect against STDs such as syphilis or gonorrhea. Visit your healthcare provider to see if PrEP is right for you. If you decide to take PrEP, you'll need to take it every day, or it's prescribed by your healthcare provider. For more information about PrEP, visit cdc.gov/HIV.
Oops, sorry, I hope you could see that. So that kind of brings us to the end of the presentation. And if there are any questions, I'm happy to take them now.
Thank you so much. Thank you so much, Dr. Devika, for the presentation. Can we hear you, please?
Yeah. So,
Okay.
oh no, sorry. I'm trying to get out of this thing and I'm stuck.
If you are sexually active or inject drugs, there are.
Sorry. I'm
So,
stuck in this screen share. Sorry, Fola. Go on.
okay, so we already have some questions in the chat box that some people
Okay.
ask that I will just relate to you. One of the question is, 1 minute, please.
Sorry, Fola. I can't get out of my Shane. Like my screen is just stuck. So yeah, if you don't mind, I cannot see the.
Yeah, I will read the questions to you. The first one is, can we use the same drug that we use for PEP for PrEP?
Yeah, so you know, that is not what the data. So PEP has the emtricitabine, tenofovir, and the dolutegravir in one pill, and then you've got emtricitabine, tenofovir, which is used for PrEP, and it is the same drug that is within the PEP regime. Yes, there's two of them that are similar, but now you have this additional integrase inhibitor that you don't want to be taking for no reason if you're actually using the oral PrEP regime. And the reason for that is that if you're going to use the injectable cabotegravir, that's fine, right? But there are risks of side effects if you start taking medications long term that you don't necessarily need to be taking. And the data is really only on the two drug regime. So even though those two drugs are part of the PEP, you don't just give them the PEP, the pill from the PEP kit for PrEP.
Okay, thank you so much. The next question is, can we actually avoid using condom once on PrEP, or do we still need to use condom while on PrEP?
Yeah, so I think one of the reasons that PrEP was even looked at is because, particularly in the men who have sex with men population, which is the first group that we talked about that PrEP was initially studied in, and then was also studied in heterosexual sex as well. Is that those individuals aren't always using condoms. And so there is a risk reduction with PrEP alone in the absence of condom use. The reason to use condoms is for the other sexually transmitted infections, and because PrEP is not 100% effective. It's quite good, like it's over 90% effective if you're taking it correctly. But whenever we talk about kind of our risk mitigation strategies, the more things we do, the more protection we have. And so in general, we would still always counsel our patients to use condoms, mainly for protection of other STIs. But as the purest form, to answer your question like directly, in general, PrEP has benefit on its own from an HIV perspective that condoms would add some benefit, but in general, some individuals will definitely use it without condoms. But as medical professionals, we should always counsel the use of condoms for those additional reasons that I just talked about.
Thank you so much. The next question is, any special consideration for pregnant and lactating women?
Yeah, so good question. When you look at all of this data, there's always gaps and there's always more research that needs to be done. And so pregnant women and lactating women are a gap in PrEP studies. So there are specific studies that excluded pregnant women, and then eventually they decided, okay, we're going to start including them towards the end of some of their studies. And so basically the number of pregnant and lactating women within all these studies that I've been talking about have been limited. So basically what we say is that the data in this population is limited. That being said, emtricitabine and tenofovir, if we use that drug specifically, that is used in pregnancy for treatment. For example, if you had to give PEP to somebody, you would also use that plus the dolutegravir. So it's not that these medications can absolutely not be used in pregnancy or in lactating women, but there is a little bit less data in them for the PrEP perspective. So this specific indication we're talking about. We also know that pregnancy or right after you've delivered and when you're lactating, there is also an increase, well, throughout that period, pregnancy and just postpartum, you are at increased risk of HIV. So basically what I would say, if you have somebody who is pregnant or lactating, you want to do a risk benefit analysis with them. And so I wouldn't say they are 100% contraindicated, but you do need to tell them that the data for PrEP, again, a long-term taking of this medication, is limited. But safety data in general suggests that it's probably okay to use in this population.
Thank you so much. Somebody asked a question here. Could PrEP lead to drug resistance in HIV/AIDS treatment?
Yeah, so so for the emtricitabine, so yes. So first of all, of course, the reason we're taking PrEP and the reason that we're telling people you must not miss your doses is that if you do miss doses and do these kind of things, if that increases your risk of acquiring HIV and yes, increases your risk of potential drug resistance. So for the emtricitabine tenofovir, there have been minimal resistance reported. But if you recall, I was talking about the integrase inhibitors in one of my slides. And in that study, so those over 8,000 group, they found 20 individuals that then ended up having HIV. And that was because some of them were HIV positive before they even started their integrase inhibitor. Some were not taking their medicine. And then if you look at all those 20, there were essentially, I think it was 6 or 7 that had what they called genotypic resistance. So when they did they looked at what medicine you can use for this individual, they found there was integrase inhibitor resistance to cabotegravir, which then conferred likely resistance to dolutegravir, which of course is in our PrEP, but is also commonly used in treatment. So those were the 6, I think it was 6 or 7 genotypic and then 2 phenotypic. So the difference between that is that the gene is showing, okay, when I look at my lab report, it says that it's resistant, but then phenotypic means that when you start checking the person's viral load, the medicine isn't bringing it down. So the numbers were really quite small. So in general, you're looking at 2 in the over 8,000 people. And so while the resistance is reported, and you didn't see any of that resistance in individuals that didn't get the integrase inhibitor, so it likely is a phenomenon. The benefit of trying to prevent all of those infections is higher. So it's definitely something to consider, which is actually the reason with that first question where we were asking, can we just use, the PEP pill as PrEP? Now you've added an integrase inhibitor that you don't really need, and you don't want to be losing integrase inhibitors for treatment if you can help it, because they're usually quite well tolerated, and better for the newer resistant strains, except that, of course, if you develop resistance to the integrase inhibitor.
Before I ask the next question, colleagues, we put one evaluation in the chat box. We'll appreciate if you can just help us look through as we are answering some of the other questions. It will take you less than 1 minute to fill in all the questions in the evaluation. You just click on the link and it will take you to another page where you can actually fill in those and respond to those questions. Somebody asked a question here that, according to you, what is the best choice in these 4 kind of PrEP?
Okay, so we talked about 3 types of traditional PrEP and then the on-demand. I am not in favor of the on-demand in general because of the increased risk or the decreased efficacy. But of course, if it was like the only thing that somebody would take, then it's something to consider. So then that leaves the oral, the ring, and then the intramuscular injection. In general, I think that at this stage, just at this moment, I think that the pill, so the emtricitabine tenofovir, is the most widely available. It has the largest indication. So in general, that's probably superior because of that, as long as you're having good adherence. But the cabotegravir, the injection, which I don't have like a timeline for when this is going to be available all over the world, but once it starts to become available for individuals that are at risk of acquiring HIV via sex, this will be, really be a good candidate despite those minimal potential resistance issues, because it's only every 2 months. You don't have to remember to take a pill all the time. As long as, we don't have individuals with needle phobia and others, I think that is going to be superior. But for now, I would say the oral medication, and then eventually probably the injection. And then as for the ring, I would say that I think for empowering women, and in terms of being discreet in others, I think the ring is really something that we need to watch as something positive. It's just that it's not fully integrated into these programs. So I think it's a little bit early. The other thing is, I would say, is the bottom line is basically anything that you can use for PrEP, if you have if it's accessible, either of those three are okay, but probably the pill for right now until we get better access to the cabotegravir.
Okay, thank you so much. One question here. Based on the duration of effectiveness of PrEP, do we tell clients to use condom before this period? I mean, you mentioned during the presentation that for 7 days for receptive anal sex, and then 21 days for receptive vaginal sex. So do we tell clients to use condom before these periods?
Yeah, so yes, that's a great question. Yes, we most definitely should, because we're not reaching that peak effectiveness. So to kind of summarize what I am trying to say is that yes, for sure, during that period while you're reaching your peak effectiveness, condom use is advised. And in general, as healthcare providers, we should be advising condom use anyway, because that does not protect against other STIs. Though purely from an HIV PrEP perspective, one of the reasons that people like PrEP is that they may not need to use condoms for that specific indication. But if you do use them, you're going to have even better protection, because nothing is 100%.
Okay. There's a question here. I think I'm going to answer that question. The question is, in most UN stations, which kind of PrEP do you send them? For now, we haven't been sending out any PrEP to any duty station. Like Dr. Dixit mentioned during our presentation, access is a major problem that WHO is currently addressing now, and UNAIDS. So the medications for PrEP are not widely accessible as of now. However, in some countries where there are access, you need to meet the criteria before you even get prescribed this medication. And also, you need to be sure that your health insurance provider, they are covering the cost for provision of PrEP, because that I can tell you is very expensive now in terms of the cost per PrEP. So you need to make sure. I know in some countries where we have UN personnel, where they have access and their insurance covers it. I mean, I was attending a meeting. I mean, if you see the cost of PrEP alone, that's a lot of money. So you need to be sure that your health insurance provider, they are covering provision of PrEP if it is available. And for now, as UN, the focus of the UN Medical Director is provision of HIV PrEP, not PrEP. So for now, we are not sending out any PrEP to any duty station. The next question is, at what age can we start PrEP?
Oh, yeah, good question. So the PrEP data, all of those studies, they've only been studied in over 18 years old. So you need to be at least 18. I think that's one of the gaps looking at this in younger individuals, but all of that data is for over 18.
Okay. People are asking whether we're going to share the presentation. Definitely, we're going to share the presentation with everybody so that you can have a copy of the presentation. And okay, is HIV testing obligatory for PrEP?
Yes. where is that? So yes, in order to initiate, so if you are doing standard of care, which is of course what we want to be doing, in order to start PrEP, you need to do an HIV test before initiation. And that's what I was, just a reminder, talking about, that they should be tested and then also do a history review to make sure they're not like, they didn't have some high risk thing happen and then are maybe in a window period or something where your test might be negative, but they're actually infected. So not only are you doing the HIV testing before you initiate, you're also going to be repeating blood work, including HIV testing, every 6 to 12 months at the beginning. That might be less if somebody's been on PrEP and is like, very adherent for like, several years or something. But in general, yes, you do want to do that.
Okay. I think this will be the final question I'm going to ask from the chat. PrEP is to prevent HIV-1. Anything for HIV-2?
Yeah, so the data, all these studies have been done in HIV-1. And so when I was looking around, I looked at what they had for HIV-2, and it was quite minimal. The difference between HIV-1 and HIV-2, there's a few. So HIV-2 tends to be a little bit like, these are just broad principles, but a little bit slower in evolution, usually having lower viral loads compared to HIV-1. Of course, can be transmitted person to person in the same way, but this data was really from HIV-1. So I found some kind of expert articles that talked about for HIV-2 that likely, because these drugs, the emtricitabine, tenofovir, this kind of thing, they have activity against HIV-2. I mean, you can use them as treatment, that most likely you're going to be able to use the same drugs for HIV-2. It's just that what I'm presenting here is what the current literature and data is saying. But as not so much off-label, but if you were running into a situation where you had like the partner had HIV-2, and then you have like the other individual that maybe needs to go on PrEP, if that is that the consideration, then you would likely be able to use the same agents. It's just that the data is limited in this group.
Okay, thank you so much, Dr. Dixit. Temptation to read one more question before we wrap up. Do you need to get a physician prescription for you to get PrEP? Again, this depends on the location where you are. In some, where that I know for now, most of the time you need a doctor's prescription before you can get PrEP in most locations. But, different countries, different regulations, maybe in some other locations, you may be able to get it over the counter instead of getting prescription for the medication from a medical doctor. I think I will wrap up here, but before we wrap up, I will need to give another note on HIV PrEP. I'm not talking about PrEP now. I'm talking of HIV PrEP, post-exposure prophylaxis. So, as many of you know, we sent out the latest batches of the HIV PrEP kits to DT stations. I know some of you have been getting back to us that, we haven't received our kits. I would just ask you to give us maybe 1 or 2 more days, or before the end of this week, or maybe March, early next week, you should be receiving the kits. The latest information from the UN Diplomatic Park Unit is that most of the kits, they are en route to their final destination. So just be patient, and then you should be getting the kit very soon. I know some of you received the new kits already, but for those who haven't, you will be receiving them shortly. Thank you, Dr. Dixit, for your presentation on HIV PrEP. We really appreciate all those information that you gave us. And just to say again, we'll be sharing the presentation to all of us so that at least we can have a copy of it. And also, what we normally do is anytime we have a presentation like this, we normally host them on the HIV PrEP, HIV dedicated web page on the UNHR portal. So you always find this presentation on this web page. So thank you so much. We really appreciate your time and your participation at this meeting. Hopefully, we'll be organizing another one in a very short while, and then we'll invite you to participate. Thank you so much. We really appreciate your time. Have a wonderful afternoon or evening or morning, wherever you're located. Thank you very much, guys. Thanks.
Thank you, everyone.
Okay, bye-bye. Please don't forget to do the survey. I know you can still do it. You don't need to do it if you haven't done it. You can still do the survey even while you are offline from this presentation. Thank you.